Okay. So for fetal monitoring, we're talking about normal baseline, and normal baseline for fetus, Kayla just said is 110 to 160. Okay? So the low end being 110, as high as 160 is what we're going to anticipate for our baseline. All right. Um, the next thing that we look at has to do with something called variability. Does anybody know what variability is?
It tells you the status of the baby, correct? The health wise of the baby, whether he's laying on a cord or head compression. Is that right?
That one is going to be more based on the if we're having decelerations and how those time with contractions. That's going to give us the better idea about if we have core compression, head compression, stuff like that. Variability does something a little bit different.
Variability would be so that the amount of beats away from the baseline tells you it can help to reassure you, if the baby is continuing to be oxygenated, or at least that's how I understood it.
Yeah, you're right. Okay. So let me see if I can find, because I'm kind of a visual person. I'm going to see if I can find us a picture real quick. I might actually be able to fix my screen issue that I created. Hold on one second. Maybe not. There we go. Okay, good. I'm gonna grab some pictures just so that we can kind of look at them together as far as variability. And we're also gonna look at our decelerations this way real quick as well. Um, so this is just a PowerPoint that I used for, oh, this is my week 2. I apologize. Let me get my week 3. I ask my computer to do way too much work. I have so many things open right now. Okay, so this is a way to look at variability. So variability has to do with variations around the baseline. So we said the normal baseline is 110 to 160, right? So if we have variations that go up and down, that actually is a normal thing that's happening for the baby. It's the give and take of the sympathetic and the parasympathetic nervous system, okay? And only oxygenated babies do this well. And so the way they do it well is with moderate variability. And so this is if you have variations around the baseline that are between 6 and 25 beats of variation. This is moderate variability. Okay. The ones that you typically see, and really the ones I really think that you probably might see as a student, I don't think you'll see all of the different ones. I think the main ones you'll see is going to be moderate variability, which is the best one, and then minimal variability. And minimal variability, do you see how these variations are smaller? The squiggly line is a
Mhm.
lot less squiggly. With minimal variability, our variations around that baseline are less than 5 beats. Okay, so on our graph, our fetal monitoring graph, each line going up is 10. So if we look back at this one for moderate, that squiggle is going more than one line up as it's going up and down. It's not rhythmic, it's all sorts of variations, but you do see that it's more than 5 beats because each one line is 10. Okay, so I know that that one is more than 6. This one is not. Do you see how it's so much less? And so if you have variations that are less than 5, then that might be a sign that the baby is developing hypoxia. It also might be a sign that your baby's sleeping. It also might be a sign that we gave mom Dilaudid and now the baby's sleepy because it crosses the placenta. So minimal variability doesn't necessarily mean anything's wrong, but it also doesn't tell us that our baby's fine. But moderate variability tells us our baby's fine. Okay. So that's variability. The other thing that we talk more about is going to be our decelerations. Okay, and I think that understanding the decelerations is probably the most important part of this because I think that's usually what you um, as students would see like on a test or on HESI or on NCLEX. Okay, so that's where we're looking at core compression, head compression, and those things. So our decelerations depend on how they time with a contraction for early and late. That's how we decide if it's early or if it's late, is where it falls in relation to the contraction. If you have a deceleration that we call a variable, that sounds like variability, like what we were just looking at, but it's a separate thing. Variable decelerations are caused by something. Does anybody know what variable decelerations are caused by?
Mhm. The
Placenta.
core compression, yeah.
It's going to be core compression. And so the thing with variable decelerations is that the timing is variable. It doesn't matter if it happens with a contraction or not. Sometimes it will, just because the contraction is what's putting pressure on the cord. But I've also seen babies squeezing their own cord, or they roll in a certain way and it's just got pressure under their shoulder, or who knows what puts pressure on a cord. So the variable decelerations don't have to time with contractions, only early and lates do. So if I go back to the pictures, okay, if we're looking at the variables, the way that we know that this is a variable is because it drops so fast. The pressure happens on the cord, heart rate drops. Okay, as soon as the pressure relieves from the cord, the heart rate comes right back up to the baseline. And so it makes that V shape, or this looks a little more like a U, but you see what I mean. It went fast because there's pressure on the cord. Pressure relieves, it comes back off, or it comes back to baseline. So these are your cord compression ones. Okay, you guys as students in class will not have to be able to read tracings. I'm showing you the picture so it makes sense in your brain. You're not going to have to look at it and identify it. But what I want you to know is what the words are. So if you see something that says like the heart rate abruptly dropped or rapidly dropped or something that's fast, that's giving you an indication that this is what's happening. Because with our other decelerations, it takes longer for it to get to the bottom. All right. So this one is our variable. This is cord compression. Next, let's look at early. Early, here it is. Early is a little misleading with the name early because it's not really early, it's actually on time. It happens at the same time that the contraction happens. So here's a contraction, and here's the deceleration, and by the time we get back to the baseline, we're at the end of the contraction. All right, and these are taking a little bit longer to get to the baseline, and they're a little more like wide. All right, if it happens at the same time, that's your keywords. That's your little cheat. For if you see those words, it happens at the same time, or it mirrors the contraction, this. Anybody know what causes this one?
Head compression.
Head compression. Okay. Now, the one that we worry
Wait,
about
what was that again?
most, this one, the early deceleration is caused by head compression.
Head
So
compression.
this is pressure that's happening to the baby coming through the birth canal. You know, everything's squeezing and it's going, and so when the contraction happens and we're getting squeezing on the head, we get that smooth deceleration that happens at the same time. For
Okay.
this one, that's not concerning. This is normal as labor's progressing. Okay, so there's not really any interventions you need to do for it. The one that we worry about the most and the one that that is going to require the most attention is the late deceleration. The late deceleration starts after, and after is your keyword or your cheat word for this, is the word after. It starts after the contraction starts. So here's the contraction. Here's the heart rate, which also has like not good variability. And now we're going to come down and we're going to see this start decreasing here, but here where it starts decreasing, if we follow it down, look at how far into the contraction we already are. Okay. And so it starts after the contraction starts. It doesn't come back to the baseline until well after the contraction ends. Anybody know what causes late decelerations?
Placental insufficiency.
Placental insufficiency. So what does that mean? Placental insufficiency. What is that?
Low perfusion, blood, not enough blood flow
Yeah.
is being provided to the baby.
And if we're not getting good blood flow through to the placenta and we're not getting that for the baby, we're not giving the baby enough oxygen, right?
Correct.
So those are the ones that we really need to pay attention to and be worried about. Those are the decelerations that are really going to drive hypoxia. Okay, and truly, if we're having a lot of late decelerations and we're doing our interventions and it's not improving, we'll do a C-section probably because that we're worried about hypoxia for that baby. What interventions do you think we would do to try to improve our perfusion, the placental perfusion?
Reposition the mom.
Reposition the mom. Why would that work?
Now where the baby's up off of the cord.
It's going to get the baby off of the mom's vena cava, right? Do you remember supine hypotension where she's on her back? The weight of the uterus can put pressure on that vessel that comes down and gives blood to the uterus. And it causes her blood pressure to go down. And anytime her blood pressure is really high or really low, it's going to affect perfusion to the placenta. So moving the mom's the good first thing to do. It gets pressure off the vena cava and improves mom's blood pressure and overall perfusion to the placenta. So it's a good first thing to do. What else might we consider doing with late decelerations?
Adding O2.
So,
You could give oxygen to up to 10 liters if she needs it.
We could give oxygen, and oxygen's on our list, but I'm going to tell you honestly, in practice, that is not a first line treatment anymore. And the reason for that is I can oxygenate mom all day long and get her oxygen saturation 100%. But if I'm not getting that good oxygenated blood perfusing to the placenta, I haven't fixed anything. Okay, so oxygen's something to remember, guys, and keep in the back of your head because in case you see it, like on HESI or NCLEX. But I want you to really think about how we're perfusing the placenta because that's going to be what brings that oxygenated blood to the baby. So one of them is going to be the position. Anything else?
What about
stopping
the IV
Pitocin.
bolus?
IV bolus is a good idea, especially if her blood pressure is low. Okay. Does anybody know there's something that we do on purpose for women during labor that can cause significant hypotension and decreased perfusion to the placenta? Does anybody know what I'm thinking of?
Epidural.
Epidural. So we actually will do an IV bolus even before we give the epidural for that. But definitely IV bolus is something that can help with our placental perfusion. The other thing to think about is going to be how much is she contracting? Every time the uterus squeezes for contractions, then the vessels that come through to feed the placenta are being compressed. And so if her contractions are too close together or they're lasting too long, that also can affect placental perfusion. So position is the first thing to do. We can consider oxygen, but IV bolus is going to help the blood pressure. We might need to give medicine to slow contractions down, which is a tocolytic medication. Does anybody know what the tocolytic we would use for this would be?
Turbulin.
Yeah, it's called terbutaline. Yep. And terbutaline, guys, has a side effect, and the side effect is tachycardia. Okay, starts with a T. So I will tell mom if we're having a lot of decelerations and I've repositioned her and I've given her fluid bolus, I turned off her Pitocin because let's slow the contractions down. And maybe if I'm inducing her, she's on Pitocin, I would turn it off. If I'm giving terbutaline, I tell her this might make you feel a little bit like you had a lot of espresso to drink because it's going to make your heart feel fast for a little bit. Okay. So those are all things we're thinking about with late decelerations. We're trying to perfuse the placenta better so we're getting good oxygenated blood to the baby. All right. Now, a way to remember all of this is going to be veal chop. And so veal chop, we made this little graph for you guys. Veal, the word veal, the word chop, and then we put the word mine next to it next. So the first word veal goes down in a line, V-E-A-L. The word chop goes down next to it, C-H-O-P. And then if you put mine next to that, M-I-N-E, that's also going to help us remember what we need to do. So the first line for veal, this is the deceleration, okay? And so V stands for what?
Variable.
Said the heart rate,
Variable.
it says the heart.
V stands for a variable. So we're looking at these different letters stand for different things that are happening with the heart rate. E stands for
Early deceleration.
early.
So,
Then A for veal chop stands for accelerations, which is the opposite. That's actually when the heart rate increases, which is really good. When we were talking before about the importance of oxygenation and how we can get an idea from moderate variability that our baby is well oxygenated, that's also true for accelerations. Babies cannot do accelerations with their heart rate if they're hypoxic. So let me just show you real quick on the acceleration, then I'll go back to veal chop. The acceleration, here's our baseline. The acceleration increases and goes up, and it needs to go up by at least 15 beats and last at least 15 seconds. That is, babies that are well oxygenated do that. Babies that are hypoxic can't do this. Okay, so when we think about veal chop, A is for accelerations, and then L is for what?
Late deceleration.
late decel.
Late. Okay, so that's your VEAL. Then you have the word chop next to it. The C is for cord compression. And so if we follow it straight across, then variables are caused by cord compression. The H is for head compression. So earlies are caused by head compression. The O is okay, and that's our accelerations. Our accelerations means our baby's well oxygenated, so that's good. And then the P of veal chop is placental insufficiency. And so that's, if we look back at the L for late, P for placental insufficiency, that's when it's the most dangerous that we talked about, all the things we need to do. Okay. So then if you have the word mine next to it also, then you can follow it straight across and say if you have variable decelerations, it's caused by cord compression. M stands for move the mom. Moving the mom, if I have cord compression, is going to help hopefully take pressure off the cord. Again, I don't know what's putting pressure on the cord, but shifting mom will shift the baby. Okay. If we follow this across, early decelerations caused by head compression, the I from mine means interventions not needed. If you have early decelerations, this is normal. So if you see on a question, it says, what is the priority intervention for early decelerations? What's the priority intervention?
Nothing.
Document.
So that's what you do. Anytime you guys see document the finding, that's only the right answer if your finding is normal. Okay. I used to get so hung up on that as a student because I'd look and I'm like, well, I definitely need to document this, but that's not the priority in the moment if something needs to be fixed. But if everything is normal, that is the only thing to do. So you could reassure the parents, document the finding. It's fine. Okay. Same for accelerations. If you're having accelerations, there's no intervention needed. So what should you do? Document the finding, right? And then L is for late. It's placental insufficiency. This E for mine is evaluate. So why are we having them? Which is why I said what could cause that. So we talked about position, blood pressure, contractions. So then what we do about it is going to be related to that. Position change is still the good first thing to do. You're going to do least invasive to most invasive, and position change is super easy and often fixes the issue. Oxygen, which Ashley had brought up, and I told you that it's not the good first thing, but it's on the list still. Okay. IV fluid to support the blood pressure. We should notify the MD in case we need to do a C-section and we're thinking about slowing contractions down with either terbutaline or turning off oxytocin. The other thing on this chart is in bold letter, or I'm sorry, in the capital letters is those little cheat words. If you see the words abrupt onset, it's a variable. If you see mirrors or happens at the same time, it's early. And if you see the word after, it's late. Okay. Other questions about fetal monitoring? If I have late decelerations, is that reassuring?
No.
No. If I have early decelerations, is it reassuring?
Yeah.
It's not non-reassuring, right?
Mm-hmm.
So yeah, it's fine if we have early, but it's not reassuring if we have late, or if we have variable. Even though variable decelerations is that cord compression, and so we get that abrupt drop and then it comes back to the baseline, is still, if that's happening every single contraction, it's kind of like holding your breath, right? After a while, that baby's gonna get tired and they're gonna have less oxygen reserve. And so even variable decelerations can be problematic, which is why we want to move the mom and get the pressure off the cord. But it's not as concerning as those late decelerations where we're really not getting good oxygen to our baby at all. So the oxygen, the biggest concern for oxygenation is going to be the late. Okay. Any other questions about fetal monitoring? Any other questions about any of the other concepts?
No, but I do have a question. Maybe you probably could answer it after
Sure.
this review. I don't
Yes.
know, but it's kind of stressing me right now.
Yeah.
So I'm in the process of trying to get my computer.
Okay. Which of the following is not a probable sign of pregnancy? Okay. So all of these are considered probable signs except the green one. All right. How do I know that red is probable and not positive?
What was the question?
So on this question, it said which of the following is not a probable sign. So it was telling you that 3 of them are probable signs. And so red, the Braxton Hicks contractions, was a probable sign. How do I know it's probable and not positive?
Because you can observe for it. It's objective.
It's objective, right? I could assess it. I could put my
You can
hands
assess
on,
it.
yeah. But how do I know it's not a positive sign?
Is it because you're like not feeling or seeing like the baby? Like you're not
Right.
feeling it, the patient's feeling the contractions, not the nurse.
Yep. And so that's kind of the key. All right. In order for it to be a positive sign, it has to come from the baby. Okay. So you either can hear the baby's heartbeat, you can see the baby on ultrasound, or you can palpate yourself, you can palpate fetal movement. If you can hear, see, or feel the baby, that's coming from the fetus. That is positive. We're positive there's a baby. If it's something that's happening with the mother, it can be it's either subjective or objective information. So Braxton Hicks contractions are objective. I could put my hands on her belly and feel that her uterus is getting tight, but it's not a guarantee that there's a baby inside there. She could have fibroids or tumors or something else. And so the only way to know for sure if it's a baby is if it's coming from the fetus. Okay? A pregnant client states that her last menstrual period was 12/1 of 18. She's been pregnant 2 other times with twins, 37 weeks that are now 2, and had a miscarriage at 8 weeks. What is her GTPAL? I'm going to try to pause it. Yeah, it still showed the answer, but that's okay. Let's look at this together. She's pregnant now. That's 1, right? Her last menstrual period was 12/1 of 2018. That doesn't matter for her GTPAL, but I think we see her again in this game, so that'll matter later. She's been pregnant 2 other times. 1, 2, so now we're up to 3. Okay. She delivered twins at 37 and 1 and that are 2, and she had a miscarriage at 8 weeks. So what is her G?
3.
3. Okay. She's pregnant now. She was pregnant with the twins, and that counts as 1 pregnancy, and then she was pregnant with the baby that she miscarried. So her G is 3. How many term deliveries has she had?
1.
1.
1. And that's the twins. Okay, the twins counts as 1 pregnancy and it counts as 1 delivery. Right? So T is 1. She's had 1 term delivery. How many preterm deliveries has she had?
0.
0. How many abortions has she had?
0. Or 1.
1,
1.
1. How many living children does she have?
2,
2.
2.
2. So she's G3, T1, A1, L2. Is she a multigravida, a prima gravida, or a nulla gravida?
multigravida,
Multi.
Multigravida. Is she a multipara, prima para, or nulla para?
Primipara.
She is a prima para. Does everybody understand that?
No, I don't understand
Can you
any.
can you can you break that down a little more? The prima pair, multipair.
So let's talk about this for a second. So the gravida part, she's a multigravida because she's had more than 1 pregnancy. Okay. For parity, it matters how many times they have completed a pregnancy that's over 20 weeks of gestation. And so she's only had that 1 delivery at 37 weeks. The other delivery was at 8 weeks. Okay, that spontaneous abortion and the miscarriage that she had. So she's really only completed 1 pregnancy past 20 weeks of gestation. So that's why prima means 1. And so she's a prima para. Okay, so gravida is how many pregnancies. Doesn't matter how they ended, doesn't matter what happened, it just matters that the pregnancy happened. But parity matters when it ended and, well, it matters when. Okay, because it doesn't matter how, like if she had a vaginal birth versus a C-section or whatever. But if it's less than 20 weeks, that counts as abortion. It doesn't count in parity. And so that's why she's considered a prima para. After she delivers this baby that she's pregnant with right now, as long as it's after 20 weeks gestation, she will be a multigravida multipara. Right now, she's a prima para. Does that make sense?
yes.
It makes sense.
Okay, good. All right, I do think we see this one again. All right. So otherwise, why did we find out her LMP? Because that wouldn't really matter what her period was. So we probably have to figure something else out with her. Oh, there she is again. She last menstrual period 12/1 of 18. Okay, it wants to know what's her estimated due date using Nagel's rule. Okay, so how do we figure out the estimated due date?
Subtract 3 months, add 7 days.
Okay,
And
so she had her period in December. So we're going to go 3 months back from December. Okay, which is why September. And I'll double check because then I'll count forward. Like I'll say, okay, if it's 9, 10, 11, 12, and then that makes sense. So 9 is the month. We're going to add 7 days. So her last period, we go by the first day of her last period. It was on 12/1, so we're going to add 7 days to that. So that's where we get the 8. And then we're going to add a year. Unless her last period is at the beginning of the year, then it's not going to go into the next year. Does that make sense? So if her last menstrual period is January, February, March, her due date will still be in the same year. So you can just ask yourself, when you look at it, does this make sense? Okay, if you need to add the year or not. All right, so she's 9/8 of 19. Everybody see how to do that?
Yeah.
Yes.
Okay. Perfect. Next question. Same girl, which describes her gravidity and parity? I didn't remember this question was in here. You guys should all get it right. Okay, she's multigravida because she's been pregnant multiple times. But she's primaparic. She's only had one delivery past 20 weeks of gestation. A client's fundal height is noted to be at the xiphoid process. The nurse is aware that which of the following fetal changes is likely to be occurring at the same time in the pregnancy? All right, so actually, this is really good. Those of you that answered this, you guys did really well with this. This one is like one that really makes you think. Because first, we got to think about the fundal height. It says the fundal height is noted to be at the xiphoid process. So what does that mean as far as how far along she probably is in her pregnancy?
She's towards the end of her pregnancy,
Yeah.
at least
Do you guys
term.
remember? Yeah. Do you guys remember how to measure fundal height?
no,
No? Okay, we'll talk about that one too. Does anybody know how to measure fundal height?
Yes, it's
Kimberly?
after 20 weeks,
look,
it goes by
if you look
gestational
up the word.
age of the fetus.
Mm-hmm.
Yeah,
It goes from the
above the umbilicus.
to the fundus, correct?
Mm-hmm. Yep. So we're measuring from the pubic symphysis, or her pubic bone, up to the top of her uterus, which is her fundus. And that measurement in centimeters should be about the same as the weeks of gestation that she is, plus or minus 2. And so we start measuring it around 20 weeks when it's about the belly button. Okay. Before that, it's hard to feel it. It's hard to measure it. In the first like 12 weeks, it's really hard to palpate it all because usually the uterus is still kind of in the bony part of the pelvis, and it doesn't really start coming up out of that until after 12 weeks. And then by 20 weeks, we're about at the belly button, and then it's going to keep going up. So if we're at the xiphoid process, we're pretty close to the end of the pregnancy. So even if we don't know the number of weeks, we can take that question and go, well, if we're at the xiphoid process, she's pretty far along. Then we can think about what's happening for fetal development at different stages of her pregnancy. And so the question said, surfactant is formed in the fetal lungs. When does that happen?
I know it happens towards the end of the
I hear what you
pregnancy
said. Can
before
you
the
say that?
baby's born.
Yeah, surfactant is formed towards the end. And that's why later this term, when we talk about preterm labor, we talk about what we need to do to help with surfactant production if a baby's going to be born early. Because the surfactant is really like the slippery substance that help the alveoli stay open. And it doesn't form till the end of the pregnancy. Okay. This patient, her fundal height's at the xiphoid process. She's probably towards the end of her pregnancy, so surfactant should be being formed also. Spinal column closes. This is an early one. Okay, and we talked about this one in relation to neurotube defects, right? The spinal column closes at like 9 weeks. So definitely not when we're at the xiphoid process. Heart begins pumping blood. That also happens very early in pregnancy, around 6 weeks gestation. So that's way before this. And eyes begin to open and close also happens very early. So for this question, we're thinking about what's happening with her pregnancy if their fundal height's at the xiphoid process. She's very far along. And then of all of these things, which thing is happening towards the end of her pregnancy? And that's the surfactant. Okay, make sense?
Yes.
At 36-week gestation, client lies flat on her back. Which of the following maternal signs or symptoms would the nurse expect to observe? Okay, dizziness. Why?
Because she's lying on her vena cava, so it causes supine hypotension.
Yeah. So we talked about this when we were talking about how we perfuse the placenta. And that if she's on her back, like moving mom is one of the good first things to do because with supine hypotension, the weight of the baby's putting pressure on the vena cava. It causes her blood pressure to go down, decreases perfusion of the placenta. Does supine hypotension have the possibility of making our baby hypoxic?
Yes.
Yes. Okay. She's feeling dizzy, her blood pressure is dropping. Okay. So if you were doing this, if you had this patient, she is feeling dizzy when she lays on her back, what would you do for her?
Turn her on her left side.
Turn her. Okay. Or if she reports she's feeling dizzy when she lays down, tell her not to lay on her back, right? Encourage her to lay on her left side. Left side helps perfuse better, but either side is good. Which statement is true about exercise during pregnancy? Okay. So we want to use exercise as a way to help her feel healthy. It's not going to be used for weight loss. We don't want her to do anything that's super vigorous. We don't want her doing things that are potentially dangerous. So low impact exercise is good, like yoga and swimming and walking and things like that. But we definitely do teach it to diabetics as a means of controlling blood sugar. So if she's if she's had diabetes before she gets pregnant, or if she develops gestational diabetes, exercise, especially after meals, can help control her blood sugar and help keep it nice and steady. Okay. It is discovered that a pregnant woman practices pica. Which of the following complications is the most often associated with this behavior? Good. This is typically an iron deficiency anemia. Okay. So what is pica? What would we see?
Eating stuff
Or even
like
forking it
ice and
open.
stuff,
Yeah.
Hey,
Yep.
Powder, dirt.
clay.
Mm-hmm.
Hmm.
Yeah. Good. So what do you think if your patient is practicing pica, then we're concerned about iron deficiency anemia, so we should notify provider, right? And she's probably going to, they'll test and probably discover she has iron deficiency. If she needs to take iron, what kind of teaching do you think would go with that?
taking something for constipation as well, like more fluids, pushing more fluids
Good idea.
off the nurse.
Yeah, good idea. Yep. What else?
Eating more fiber, green leafy food, things like that.
Yeah. What else?
Take it on an empty stomach, and with vitamin C.
Good. Yeah, vitamin C helps with the absorption. Is there anything that can decrease absorption for iron?
Dairy.
Dairy. Yep. The other one that I actually was surprised when I learned about it is that coffee and tea also affect absorption. So she doesn't want to use coffee, tea, or dairy products or calcium products when she's taking her iron. But vitamin C is good for absorption.
So you're saying the caffeine basically is what?
I don't
Yeah.
know if it's exactly caffeine that is the reason. I just know the coffee
Mhm.
and tea. I was like surprised, but let me check real quick.
Okay.
Let's see, does caffeine affect of iron? I wasn't watching what I typed and I had a misspelling and it instead told me about risks for preterm labor. It says coffee and tea rather than caffeine itself significantly inhibit the absorption of non-heme iron or plant-based iron when consumed with meals.
Mhm.
So I guess it's not specifically the caffeine,
Caffeine.
it's the fact that it is the coffee and tea. But in
Mhm.
like for your diet, if you're having them get their iron through eating like meat and fish and poultry, then caffeine drinks and those things don't affect it.
Okay.
Yeah. All right. A woman's 36-week gestation, which of the following tests will be done during her prenatal visit? Okay, good. This is when we're going to check group B strap. All right. The group B strap, what is this test that we're doing and why is it important? Oh, shoot. Did we just get kicked out of our game? Well, we'll see what happens. But let's talk about this for a second. We're gonna let that see if it resets itself. I've never had that happen before. Um, but what would be the reason? What are we checking for GBS, and why is it important?
Is it fetal abnormalities?
No, it's a good thought, but that's not what it is.
We're checking for strep.
Yep, we're checking for strep, group B strep,
It's
and any
bacteria.
idea why that matters?
I
It
wouldn't.
can pass through to the baby and infect the baby when they're born through the birth canal.
Exactly. So what will we do to prevent that if it's positive?
When the mom going
Mhm.
some type of antibiotic?
Ain't it penicillin?
Mhm.
Is it penicillin?
Mm-hmm. Yeah, we're going to give her antibiotics, and it's usually penicillin unless she's allergic. So, so here's the thing. So group B strep is a bacteria that lives in the normal flora. It comes and goes. So a mom might be positive in one pregnancy and not positive in another pregnancy. It doesn't really bother us. It's kind of like all the little things that live on our skin, on our hands, and stuff like that. But if a baby contracts it, it can be very dangerous for a baby. It has a mortality rate up to 50%. So we do swab at the end of pregnancy around 36 or 37 weeks. We do a swab and we check for group B strep, and if it's positive, we give mom antibiotics during labor. I think the other ones that were on that I was going to talk about were the other testings. One of them was amniocentesis. Does anybody know what we do that one for?
It's the fluid that's around the baby, but that's where the waste in the urine is.
Yep. But that's also where like we can see all of the chromosomal things with the amniotic fluid as well.
Okay.
So we can do an amniocentesis to check like definitively for Down syndrome and things like that. We'll
Oh, I
show.
had it mixed up. So it's the amniocentesis that check for like fetal abnormalities, like birth defects.
Mhm. Yes. And so that one though, if I need to get that amniotic fluid out, then that's very invasive, right? They have to put a needle in and they have to aspirate it. What kind of risks could go with that?
Breathing.
Infection.
Losing a baby.
Yeah. So if we're doing it early in pregnancy and looking for chromosomal abnormalities, it can cause her to miscarry, also risk of infection. Sometimes we also can do it later in pregnancy to check fetal lung maturity because that the baby is breathing in that amniotic fluid into their alveoli, and it leaves certain proteins in the amniotic fluid we can look for, which is called an LS ratio. So then if we're doing it later in pregnancy for fetal lung maturity, then we're looking more at preterm labor and things like that. So it just depends on where we're at. So but it's very invasive, and so it's going to be kind of a risk benefit thing for that test. I'm trying to think what other ones were on the question. I can't believe that this game is not coming back up either. This room is closed. Why? Hmm.
Can we come out and come back in? Because it's important.
Well, let me see. So what I'm going to do, I had it set to go in order, so I can restart it if I need to. But I was going to see if I also have this game in Kahoot, because if Blue gets messing up, I might want to switch to Kahoot instead. We can still play, and we can just skip. I'm just trying to see if we can go in order so we can skip the questions we already saw. Otherwise, we're like a quarter of the way through the game already.
Oh, how many questions did y'all do? Because I'm late.
Oh, there was 44 questions in the game, and we were only like on question 10. We started out talking, we talked a whole lot, like for half an hour, we talked about fetal monitoring and stuff first.
Okay.
Yeah. I usually really take my time with this first review, so if you can't stay, that's okay, because usually like most of the time our reviews are like an hour, but this one I usually spend much longer
Yeah,
than an hour.
I got all time, all day long.
I
Wait a
got
minute.
all the time.
Important. So we
Um,
gotta start this over, please, because we only did 10 out of 44.
I know, I'm looking. Let me see if I have it in Kahoot. If not, we'll play it in Blue Kit again. I'm just
Let
nervous
me
because
do y'all 10 since I was late. Let me do y'all 10 real quick.
I don't
I'll
know.
just bump. Well, I know, but well, I guess we'll go through them quickly. I
Okay.
thought I put exam one in. I thought I put exam one in
Miss
here, but I
McBride,
don't see it.
can't this be reviewed later on though, or at another day because this being recorded?
Yeah, you're going to be able to go back and watch.
Yeah.
We don't have
Yep.
access. Zeller class don't have access to these recordings.
Yeah, she'll post them for you.
Okay.
She will. Yeah, she will. All right. I send my recording to all the instructors, and actually they all are sending the recordings out. Okay, we're gonna do it again. Same one because I don't have it in Kahoot. I only have it in here. But we're gonna do the first ones very quickly. So we want to in the order, and you gotta re-sign in. I'm so sorry. I've never had this problem with this game before.
Oh, now let me log on and come right back in.
So there's a new code. I just put the link in the chat.
Oh, it's in the chat. Let's see. How you see it?
There's a link. It's a QR code right here too.
Where?
There's also the QR code on my screen. Or you can go to play.bluekit.com and enter in the 784492.
Send it to me, Deja, because I don't see it.
You don't see the QR code? Look on the screen that we looking at right
On
now.
my screen.
Mine say booklet. This room is closed.
I don't know. Did you scan the QR code? Go to your camera and
You
scan
can
the
close
QR.
that window.
Yeah, you have to close that window. We have to start over.
Oh, okay. Oh, okay, I see it now.
Yeah. I'm so sorry. That's very annoying that that happened. I'm sorry.
I'm loving it. That's more the better.
You're like, we'll just do this all day.
Shoot. Repetition is the key to anything.
Is everybody in?
Yep.
Okay, we're gonna do the first questions quick. All right.
Yep.
So for those of you that came in late, you'll get to see them, but we're gonna do them quickly. And then keep going from there. Which is not a probable sign of pregnancy? Okay, good. So guys, a probable sign, anything that is objective that you can assess is going to be presumptive unless I'm sorry, oh my gosh, it's probable if it's objective unless it's coming from the baby. If it's coming from the baby, it's positive. This girl, we see her for 3 questions in a row. We did her GTPAL. She's pregnant, she has the twins, and she had the miscarriage. She's a G3 T1 P0 A1L2. Okay, see, we didn't get this right. So hold on. She's pregnant now, had the twins, had the miscarriage. That's a G3. 1-term delivery. Okay, the twins count as 1. All right, so those of you that picked red, it's really only T1, not T2. All right. Same girl, what's her estimated due date? How do we do Nagel's rule?
Minus 3 months, add 7 days, add a year.
Yep. And then Lauren asked in the chat if you guys can play the game when the review's over. I can try to set a link for you guys to play it, but it only lasts for a certain number of days. So no promises. Same girl, gravidity and parity. So remember we talked about how she's had multiple pregnancies, so she's a multigravida, but she's only a prima para because she's only completed 1 pregnancy past 20 weeks.
Oh, damn. Darn.
The fundal heights of the xiphoid process, what following fetal changes are likely occurring at the same time? So this one we talked about how if the fundal heights of the xiphoid process, she's pretty far in her pregnancy. And so the surfactant is forming. The other things are early pregnancy, fetal development things. 36-week gestation, client lies flat on her back, which the following maternal signs and symptoms would the nurse expect to observe? So we're thinking supine hypotension, pressure on the vena cava, affects perfusion to the placenta, makes the mom feel like garbage because her blood pressure drops. So dizziness, good. Which statement is true about exercise during pregnancy? This one we talked about. Low impact exercises are good in pregnancy, and we use exercise to help control blood sugar for diabetics. It's discovered that pregnant women practices pica. Which of the following complications is most often observed with this behavior? So pica is when they eat dirt, chalk, clay, freezer frost, things like that, which is a sign of iron deficiency anemia. So we talked about education related to preventing constipation, and how to take your iron with vitamin C, but not with dairy products, coffee, or tea. A woman is 36 weeks gestation. Which of the following tests will be done during her prenatal visit? So this is where we were at. Okay, good. So we talked about the Group B strap. The other ones I want to talk about RH incompatibility. Okay. Why is what I don't know how I'm trying to ask this. What's important to know related to RH as far as pregnancy goes?
That the blood, the mother and the mother can possibly attack the fetal blood or the attack under blood, I know for sure.
So which RH would be like if mom's RH is positive or negative, which is it the concern?
RH negative,
Mm-hmm. And then it's if the baby is RH what?
positive, the baby would be.
Right. So we don't know. Okay. We don't know what the baby is until the baby's born. And so if any time a mom's RH is negative, we give her something to keep her body from building antibodies towards the Rh positive blood, just in case something happens. Remember, guys, maternal blood and fetal blood don't mix. But if there's like trauma or something that causes that little single cell barrier to be disrupted, we don't want her body to go, what is this? And start making antibodies against it. So what do we give the moms?
Program.
Program. Okay. So all Rh negative moms get RhoGAM at around 28 weeks. And then when the baby's born, we'll test the baby's blood type. If the baby's blood type is positive, we'll give her RhoGAM again. If the baby's blood type is negative, we don't need to give her RhoGAM again. Okay. Also important if she has a miscarriage that we also give RhoGAM because we don't know if that baby was Rh positive. Okay. And then the glucose tolerance test. What is that one?
To check if she has gestational diabetes.
Yep, good. And so if a woman has diabetes when she gets pregnant, we don't need to check for diabetes. We already know she's diabetic. But some women can develop diabetes during their pregnancy, and so we do glucose tolerance tests to see if they've developed a gestational diabetes. And then if so, then there's all sorts of considerations that go with that. And that's one of the high-risk pregnancy things we learn about in week 5.
I got a question. As far as gestational diabetes go, what is the rule of insulin or what they supposed to do as far as like the amount of weeks that they're pregnant? Is they supposed to add more? Because I seen a question about that.
So yeah, it depends. Okay. So a couple of things with diabetes and pregnancy, and we're going to spend a lot more time learning about this in week 5. But if a mom has diabetes, her body is resistant to insulin, right? And so as her pregnancy progresses, that insulin resistance gets more and more significant, and so her insulin needs become greater.
Okay.
For a mom who develops gestational diabetes, sometimes she doesn't need insulin. It can be managed with diet and exercise. So that goes back to exercise with meals to help control blood sugar that we talked about on that other question. We teach them how to do their glucose checks. We have them watching their glucose closely. We need to keep those blood sugars under control. And so if it's not well controlled with diet and exercise, then she also, even as a gestational diabetic, might need insulin as well. But your pre-gestational diabetic had diabetes before she got pregnant. Her insulin needs at the beginning of pregnancy are going to be a lot lower than by the end of pregnancy because it keeps going
Oh,
up as her
gotcha.
body gets more and more insulin resistant.
Gotcha. Okay.
Okay, the body tries to hang on to glucose to grow that baby. Gravida refers to which of the following descriptions? Okay, number of times she's been pregnant. Gravida's pregnancies. A prenatal nurse recommends folic acid supplements to a pregnant client. Which of the following defects can occur if the neonate as a result of folic acid deficiency? Good. So spina bifida is the neurotube defect. It's one of them. Okay. We also can see meningoceal, where again that spinal column doesn't close properly. So you can see like outpouching of the nerves in the back. We could also see something called anencephaly, where not all of the brain forms correctly. So all of these reasons, folic acid is an important thing to help that neurotube close correctly. And it's going to be best if she starts taking folic acid before she even gets pregnant. Which of the following clients should the nurse be concerned about regarding weight gain? Okay, 15 pounds and is in her first trimester. If a woman has a normal BMI, how much weight should she gain in the first trimester?
25 to, is it 25 to 35?
1 to
That's for
3
the
or
whole
2 to 3
pregnancy.
pounds.
That's
Yeah.
the whole
Yeah,
pregnancy.
4.
yeah. So like 3 or 4 pounds. That first trimester, that first 12 weeks, there's not a lot of things happening that really weigh a lot. Okay, we talked already when we were talking about fundal height that at the end of that first trimester, 12 weeks, the uterus is just barely grown enough to start coming out of the bony part of the pelvis. So the baby is tiny, the amniotic fluid, the placenta, everything's small and doesn't weigh a lot. Plus, she might have lost some weight with nausea and vomiting at the beginning of her pregnancy and stuff like that. So in the beginning, the first trimester, she probably will only gain a few pounds. You are correct that 25 to 35 pounds is the ideal weight gain over the course of the pregnancy. And so usually they gain about a half a pound to a pound a week after that first trimester. This client has gained 15 pounds in her first trimester. So we really need to kind of figure out why that's happening. That's concerning. The other options for this client who's gained 25 pounds and is in her third trimester, that's good, right? A client who has gained 4 pounds and is in her first trimester, that's okay. Client who has gained 20 pounds and is in her second trimester is still okay. We're still in those ranges. Okay. Most of the time we talk about weight gain in relation to a normal BMI. What do you guys remember what BMI is considered obesity?
30?
30.
Greater than 30. If she's considered obese, they might recommend that she gain less than that ballpark that we're saying. And if she's underweight, then they might recommend that she gain more, little bit. A nurse working in a prenatal clinic is providing education to a client who's pregnant. The client does not like milk. What is a good source of calcium that the nurse can recommend? Okay, good. Dark leafy green vegetables. So this is one thing. She can get some of that through her supplementation with her prenatal vitamins or even taking another source of calcium, but we don't want that to be the main way she's getting her nutrients. There's a lot better absorption of your nutrients if you're getting it through your diet. And so we don't want to just say, oh, you just need to take more vitamins. We need to give her encouragement to increase her intake of foods that are going to have that those things in them. The physician has documented the presence of Chadwick's sign. The nurse determines this sign indicates what? Okay, yeah, Chadwick's sign is that bluish discoloration of the cervix. What sign of pregnancy is Chadwick's sign? Presumptive, probable, or positive?
Probable.
Probable.
Good, probable. This one, presence of HCG in the urine.
Positive.
Is that presumptive, probable, or positive?
Positive.
Probable. It's probable.
Oh no, that would be
Probable.
probable.
This is also probable. Remember, guys, it's only positive if it's coming from the fetus. The HCG is coming from the mother. Okay? Which purposes of placental functioning should the nurse include in a prenatal class? Yep, oxygen, nutrients, and then waste. So how does this work?
With the through the vessels, the two arteries and the one vein, and the waste will diffuse.
The amniotic fluid too.
I don't know if I'm
Through the
saying
kidneys.
it correctly.
Oh no, through the kidneys.
Okay, so
Better.
it's important, guys, to just remember, correct, that the arteries and the vein and the umbilical cord is going to bring in the good stuff and take out the waste, okay? But that's just our transportation, all right? It's like the bus that carries in all the good people and carries out all the wasteful people. It is not, none of the exchanging is happening in the umbilical cord. It all happens in the placenta. So the fetal capillaries lay within the placenta. And so when we talked earlier about the importance of perfusing that placenta well, so that the good oxygenated blood comes into the placenta, and then correct whoever said diffusion, because that's where we're going to take all of the good stuff from the maternal blood and diffuse into the fetal capillaries because we're not mixing blood, right? And then all the waste diffuses back to go out back into mom's circulation for excretion. So it all is happening in the placenta, okay? And then which vessel in the umbilical cord has the oxygenated blood and the nutrients?
The
That takes the
veins.
baby.
The veins,
vein.
cause yeah.
One vein. Two
One vein.
arteries.
Or vein.
Arteries
Yes.
take the waste out. Waste away, and the vein brings in the oxygen. The amniotic fluid cushions and protects, and the amniotic fluid allows for fetal movement. The first maternal perception of fetal movement commonly felt as a fluttering feeling, usually occurring around the 18th and 20th week of gestation. This is quickening. Quickening is what sign of pregnancy?
It is presumption.
Yep. So even though this is the first fetal movements, it's something she tells you, it's not something you can assess. So you're correct that this is presumptive. Who knows what lightning is?
It's when they say your baby dropped. They're like, girl, your baby dropped.
Your baby dropped. Okay, so lightning is the baby drops. And so how does the baby drop?
It's dropped lower down in the pelvis, ready for delivery.
And so that's actually engagement. When the head descends into the pelvic inlet and engages in the pelvis, that it drops, right? Because now it's moved down more, and that's also lightning. So lightning and engagement are in the same thing. Okay, so dropping and lightning and engagement are all together. Okay. The nurse suspects umbilical cord compression if which is noted on the external monitor tracing during a contraction. Okay.
Sorry.
Cord
Veal
compression, veal chop. If we have cord compression, that's the C. That's why I said if you write the word veal and you write the word chop, if you write it in a line, you can go back and forth and look at them across. Okay. Cord compression causes variable decelerations. Variable decelerations is not the same as variability. Variability is the squiggly line. Variable decelerations are the V-shaped, the abrupt onset from the pressure on the cord. What's the first thing we should do for this patient? So we're suspecting cord compression. Yep, let's turn it.
Let's go.
People don't back up for a second. I want to bump into you.
Yep, we're going to turn mom and try to get pressure off the cord.
I'm trying so hard not to.
The nurse notices the presence of accelerations on the electronic fetal monitoring tracing. What is the most appropriate? Remember what we said, guys, if you have something that looks normal, what are you supposed to do?
document. And yeah. Document.
Good. All right. If your assessment is normal, document the finding. If your assessment is abnormal, you need an intervention. All right. So accelerations are normal and reassuring. We're going to document. Which assessment data can be determined by examining the fetal heart rate strip from the electronic fetal monitor? I said this as like the first thing I said to you guys today. Good. This is oxygenation. Okay. That is really the whole reason we're doing fetal monitoring, is to tell if our baby is oxygenated. If we're worried our baby's not well oxygenated, then we might be considering a different route of delivery. Okay, so it's just to prevent hypoxia. The nurse realizes that the most common and potentially harmful maternal complication of epidural anesthesia would be what?
Hypotension. Oh. Sorry.
It's okay. Good. Hypotension. What do we do to try to minimize the hypotension that might happen with an epidural?
Fluids.
We're going to give fluid bolus. Before let me see if there's anything else to talk about on here. We're going to give a fluid bolus before the epidural to help support our blood pressure. What is this one, the red one? Severe postpartum headache.
Preeclampsia.
In this context, it is asking about as a potential harmful effect from the epidural. Do you know anything that could cause a postpartum headache from an epidural?
Is it
You
hemorrhage?
hit a nerve. You hit a nerve.
Leaking CSF.
There we go. Shadi's got it. So it is possible when they place the epidural for them to accidentally nick that next layer, which is the dura. If they do that, it's going to cause a leak of the cerebrospinal fluid. When that
Oh,
happens, you get what's called a post-dural puncture headache. We're not going to notice it today on labor and delivery. We're going to notice it tomorrow on postpartum after it's had some time to leak. And the thing that's classic for a post-dural puncture headache is going to be if she feels fine when she's laying down and then she has severe pain when she sits up, because we have decreased circulating CSF, and so it causes a lot of pain in her head when she sits up, because then that all shifts. Does anybody know how we fix this?
I know if they do surgery, they give them caffeine, but I don't know if that's the same thing for this case.
So you can do caffeine. Yep, and that's going to
Okay.
be our less invasive treatment, is going to be
Okay.
caffeine. But there's another thing we can do
will you
as well.
reposition them?
Was it the blood patch?
You would
So,
give
okay, so the blood patch is going to be the thing that really fixes. You can do
Mm,
conservative measurements. So you can do caffeine, you can do repositioning, but how is she going to take care of a newborn if she has to lay down for 2 weeks? Because it's going to
mm,
take a long time for that to resolve on its own. It will fix itself, but she's got a new baby. And so it's hard to, like, if you're excruciating when you're sitting up, like you can't function, right? So the blood patch, I think Marie said, that's the thing that they could do. The blood patch, the way they do it is they take some blood from mom, give it to the anesthesia provider, who goes back into that epidural space with a needle and actually puts mom's blood into the space, and it creates a blood patch. It's a space holder. It's going to keep this from continuing to leak, and it's going to offset that space as far as the amount of fluid that we've lost that's caused that equilibrium upset. She feels better almost instantly with the blood
mm.
patch. Okay. All right. A client at 36 weeks complains of discomfort with irregularly occurring contractions. The nurse instructs the client to do what? Okay. So, what do you think? She's 36 weeks. She's having irregular contractions that are causing discomfort. Do you think she's in labor?
No, she's
No.
gonna walk, and if it don't subside, that means it's active. If it subsides, that means it was false labor.
Yeah, good. So that's kind of the whole idea. There's a few ideas with this, and so Dacia's completely correct in what she's saying. That what we'll usually do if a patient comes in and she's like, I'm having contractions, I don't know, we're going to check the baby. And if the baby's fine, then we don't have to keep her on the monitor. We'll check her cervix, because how will I really know if she's in labor? Like, really know?
you check if she's
Her
dilated.
cervix, you'll see how she
Yeah,
dilated.
cervical change. If the cervix changes. So we'll get a check, we'll check her cervix, and then we'll send her walking. If it's Braxton Hicks contractions, oftentimes they subside with activity, or they subside with comfort measures. So she could walk, she could take a tub, she could take, PO hydration helps, and see how she's feeling. And she's 36 weeks. Is she term?
No,
No.
No, I don't want her to be in labor today unless she's really in labor today, right? So we will do those things and see if the contractions subside. Correct that if they increase in intensity and frequency with activity, that could be a sign of true labor. And so then we'll check her cervix again and see if her cervix is changing, because that's how we're really going to know if she's in labor, is if we're getting cervical change. Okay. But usually those irregular contractions that happen with Braxton Hicks will resolve with activity. She's probably going home. Which of the following answers best describes the stage of pregnancy in which maternal and fetal blood are exchanged? Y'all better get this one right because I've said it like 8 times. Okay, well, all but one of you got it. All right, so maternal and fetal blood should not be exchanged. Okay. Which of these is not a probable cause of intrauterine growth restriction? Okay, good. So balanced diet high in complex carbs is not going to cause a growth restriction. And actually, complex carbs is one of our main source of nutrients, right? So we want women to eat complex carbs. All of these other things can cause intrauterine growth restriction. So what is intrauterine growth restriction?
When you got a small baby.
Mm-hmm. It's a small baby. Why do you think that these things can cause our baby to be small?
Because it's restricting the growth. Your smoking is restricting the growth. Infections is restricting the growth. Is restricting the growth.
Yep.
They
All of
reduce
these things can
perfusion.
cause.
Yeah.
Yes. Good. That's the other part I wanted you guys to think about is that we talked earlier about how when we talked about placental insufficiency and late decels and all that, we talked about placental perfusion in like an acute setting. But if you have chronic placental perfusion issues, you have vasoconstriction because you're smoking, because you're hypertensive, or because you have a torch infection, that's going to affect the way we grow these babies over time. Okay, and so these babies are going to be smaller. And actually, we talk more later in the term about what we call symmetric versus asymmetric. Um, and and so if we're having a chronic issue that is impairing fetal growth over time, those babies will be asymmetric, where their head will be like normal size and their bodies will be little. Because the body gives the oxygen to the brain first. Which is the best way to support a laboring client coping well during contractions? Okay, so in my class this week, we talked about how to know if a woman is coping and how to support that. Um, we know that labor is not a pain-free process. All right. And so if she's able to focus and manage her contractions, that's great. So let's not disturb her focus. And so I think that oftentimes, especially if they come in and they're like delivering very soon, they're very actively laboring, we want to ask them questions and find out things. And we need to let her focus, let her breathe, whatever she needs to do. And then in between the contractions, we can talk to her some more. Okay. We don't need to encourage an epidural if she's coping well. In fact, I don't automatically encourage an epidural anyway. I wait for her to ask for it. Like early on, before she's in pain, we talk about options, and you let me know what you think you need. Okay. And I'm also not asking her pain scale. I know this is a painful process. There's times where using the pain scale in OB is appropriate, like when we're giving medication. I want to know her pain scale then. But if she looks like she's coping, I'm not talking about it. I will say she's coping well. Which is also why pain is not one of our 5 Ps. The nurse would teach the client to report all of these except which one that is not a warning sign of pregnancy. Okay, urinary frequency is something that normally happens. Early in pregnancy, we get urinary frequency as part of, you remember our signs, Hager sign, Goodell sign, all of those that cause softening. Hager's sign softens lower uterine segment and puts pressure on the bladder, and that's why early in pregnancy women pee a lot. Later in pregnancy, especially when the baby drops or engages lightning, all of those things we talked about, more pressure on the bladder. So frequency in and of itself is not concerning unless she's having urgency and burning. Okay. Everything else on here could be concerning, right? If she's leaking fluid, unless she's term, if she's having vaginal bleeding, if she's having the heartburn and epigastric pain and a headache, what could that be?
Eclampsia. Preeclampsia.
Could be preeclampsia. Leaking fluid could be rupturing membranes too soon. It could be something related to preterm labor. Vaginal bleeding. We're going to learn more about placenta previa and placental abruption, but those would be things that would be concerning. So these are all things we would want for her to report to us. She was experiencing them. Which is not one of the 5 P's affecting labor. I should have known this question was in here. Did you see the game tried to cut out again? I don't know why we're having problems with it today.
Oh no.
Not a 5P. I just said it on the previous slide, but it's okay. And when we were talking about pain management and coping, and I said, and that's why pain isn't one of our 5 Ps.
Oh,
What are the 5 Ps?
Power, physiologic response, psych.
Yeah.
Passage. Got
Yeah.
passage, powers.
And position of mother then.
Got position.
Position.
Passage, power, position of the mom, psychologic response. Wait, power? Okay, passenger. Somehow we didn't say passenger, did we?
No,
Passenger.
we didn't.
Passenger, passageway, position, power, psychologic response. Okay. So the baby is our passenger and the passageway is our pelvis. So a lot of that with what we talk about with the cardinal movements of labor, the baby engaging in the pelvis, descending through the pelvic inlet, all of those things with the way the baby comes through the pelvis is our passenger, our passageway. Our power is our contractions. And then mom's position can affect the way the baby comes through the pelvis, can help us get the baby in a good position or create space, and then how she's coping or her psych. When teaching non-pharmacological pain management, the nurse educates the client about a technique to prevent the painful stimuli from entering the brain. Okay, so this is called gate control theory. Does anybody understand what gate control theory is?
Yeah, when the gate is open, that's when you get stimuli. When the gate is closed, that's all I know.
Yep. And so what closes the gate?
Another stimuli.
Mm-hmm. Yep. So it kind of operates with the idea that there can only be one nerve impulse at a time. So if we have a positive nerve impulse, then it closes the gate and it's not letting the negative impulse on that nerve root. And so things like massage and stuff like that can stimulate positive chemoreceptors that then makes the brain not pay as much attention to the pain because we're not getting all of those nerve impulses. Okay, so that's gate control theory. For focused breathing is also a way to help with pain management. And focused breathing is really important to help them also kind of be able to manage their getting through their contractions. There's different breathing techniques we use depending on where they're at, as far as if we're doing like slow and breathing or if we're doing faster puffs and blows. It's important also to make sure they're not hyperventilating. And that also comes back to how they're tolerating their labor as well. So focused breathing is an important thing to use, but it's not part of gait control theory specifically. Fetal heart deceleration is caused by uteroplacental insufficiency. Yep. If we're having, so I know that Veal Chop says P for placental insufficiency, so I specifically made sure this says uteroplacental insufficiency so you guys understand it's the same. So when we talk about how we're perfusing the placenta, we have to get that blood through the uterus to the placenta. So uteroplacental insufficiency is still the same thing. Okay. So another question again, if the game's going to be available on its own, I don't know. Okay, this game it's not easy to post, and if I am able to send out the link, it's only good for I think 7 days. So I'll try. Really, the big part of playing the game is also discussing the questions and all of the different answers and the rationales. Upright positioning in the second stage of labor causes a 10 to 30 millimeter mercury increase in downward pressure. Why is that beneficial? Okay, so upright positioning is going to help with fetal descent. What's the second stage of labor?
When you're fully dilated.
Fully dilated until what? When does the second stage end?
Till you give birth.
Giving birth.
Good. Yeah, so the second stage is going to be basically when we're pushing. So being in a more upright position like squatting can help aid with descent and help bring the baby down and out. This is also a position that we can use for the first stage of labor as well to help the baby come down through the pelvis more and descend. An assessment tool to evaluate fetal well-being and assess for potential fetal compromise.
Oh, dang, I think I messed that up.
Okay, so we talked about amniocentesis earlier, guys, remember? Where they put the needle and take amniotic fluid out. Is that going to let us know how our baby's doing? Is it going to assess fetal well-being?
No, that's for chromosomal or chromosome defects.
Yeah. Okay. So amniocentesis isn't the best choice for this. Okay. An amniotic fluid index looks at how much amniotic fluid there is, and actually our biophysical profile includes that. So our biophysical profile is like the umbrella that includes a lot of different things. So with the biophysical profile, does anybody know how we do it?
You said something
Is it
about a
a
needle, right?
Say that again.
You said that they use a needle, right?
Not for the biophysical profile. They use the needle for the amniocentesis.
Oh,
The fetal movement.
Fetal movement is one of the things it looks at.
Is that where you rate certain categories? I just can't remember.
I think this is also when they check to see how well you can do with labor, right?
Not quite. So I think, Daisha, you're thinking of a contraction stress test. And with a contraction stress test, we can give oxytocin and make her have contractions and see how the baby tolerates those contractions to see if we see late decelerations. The biophysical profile is different. And so let's talk about that because this is one that we use a lot if we have concerns about fetal well-being, and typically the first thing to do is a non-stress test where we just put them on the monitor and we watch at the fetal heart tracing. And on a non-stress test, we're looking for all those things we talked about earlier today about fetal monitoring. We're looking for that normal baseline. We're looking for moderate variability. We're looking for no decelerations, and we're looking on a non-stress test, you'd like to see at least 2 accelerations in a 20-minute tracing. If we have somebody who's maybe not feeling their baby move, and we're concerned about fetal well-being for any reason, then the non-stress test is the first good thing to do. But if it's not reassuring, then the next thing is the biophysical profile. And the biophysical profile does look at different categories and give a score. And the way that we look at those other categories is with an ultrasound. So we do the non-stress test, and then we also put an ultrasound on her and we look for fetal movement. We look at the amniotic fluid level. We look for breathing movement by the baby. Let me think. Breathing movement, amniotic fluid level, muscle tone, if the baby looks floppy, or if they have good muscle tone. I think that's it. So we look at all these different categories, and it gives us an indicator that the baby's doing well. If that score is low, that's not an indicator that the baby's doing well. That could be a sign of fetal compromise. So I've seen that happen. There was a patient that came in because she hadn't been feeling her baby move. We did a non-stress test. It wasn't reassuring. We did the biophysical profile. The score was low, and they did a C-section. And the baby's 1 minute after was a 3, which is not good. Okay, so it's probably a good thing that she came in. That's one of the things you want your patients to tell you. When we were talking before on that other question about things that she should report if she's noticing decreased fetal movement, because wiggly babies are well oxygenated. If the baby's not moving, it could be sleeping, it could be a whole lot of reasons, but it also could mean hypoxia. We don't know. So for this question, assessment tool to evaluate fetal well-being and assess for potential fetal compromise, that's the biophysical profile, or the BPP. Which would not be recommended advice for a patient with constipation? Yep, so as nurses, we're not recommending these things. Okay, mineral oil, enemas, and castor oil. Castor oil especially, it can cause diarrhea, which can cause dehydration, which is not good. It also can cause her to go into labor. That's why some people will take castor oil to try to go into labor. And so we're not going to encourage her to take any of these. All of the rest of this is things that would be helpful to her. Hydration, high fiber diet, exercising, ambulating, maintaining a regular bowel schedule. So not like holding it and kind of just relaxing instead of straining on the toilet. Things like that are all good things for her to learn. But we're not encouraging her to take these other things unless it's ordered or recommended by her provider. A nurse working in a prenatal clinic is providing education to a client who's pregnant. The client does not like milk. We did this question, right? I think that this is just, so we want to do the leafy greens and the chia seeds. We want to encourage her to get her calcium from her diet instead of just relying on a supplement. And that's going to be true with other things too, not just with dairy. What would be the first intervention to try for an abnormal fetal heart tracing, such as late or variable decelerations? Okay, so maternal position change is going to help with lates because why does maternal, we talked about earlier, but why does maternal position change help with late decelerations?
Because it can be a cord compression.
Not for this. Remember what causes late decelerations?
A placenta insufficiency.
Mm-hmm. And so maternal position change can help, like thinking like supine hypotension again, right? Getting the baby, not putting pressure on the vena cava, having the most perfusion possible to the placenta. Now, along the lines of what Daisha said, how would a position change help with variable decelerations?
Yes.
That's going to
Takes
help take the
pressure off
pressure
the
off.
cord.
There you go. Yep, good. So it's a good first thing to do for either of them, but I just want you guys to understand why for each one. Which patient does not need a dietitian to assist in evaluation and planning of nutritional needs during pregnancy? Okay, so our uncomplicated low-risk pregnancy doesn't need a dietitian. Everybody else on here, all of these could benefit from one. All right. Our diabetic, because that we need her to learn how to make good food choices, right? She still needs carbohydrates to grow her baby, but how to pick like the good nutritious carbohydrates. Our adolescent has a lot of nutritional needs. They are not good at picking good foods. They have body image issues. They don't want to be fat. Their body is also using nutrients for their own growth still as well. And they also have higher risk of having babies with IUGR. They also have a higher risk of having babies, with having iron deficiency anemia for themselves. Vegetarians and different cultural and ethnic food patterns, that's going to create opportunities for a dietitian to help them pick. So again, to try to get as many of their nutrients from their diet as they can. So vegetarians and different ethnicities that eat certain things all the time might be lacking in certain nutrients. And so a dietitian can help them as well. Which is a sign labor may begin soon? We are all over the place on this one. What's quickening?
Fluttering.
Yep.
First movement.
So that happens. Yeah, those are those first movements, right? So that's not a sign labor starting. Urgency. We could see more urgency if the baby's engaged or dropped, but that doesn't mean that the labor is going to start soon. Babies sometimes will engage in the pelvis weeks before. Absence of fetal movement. We shouldn't ever be experiencing absence of fetal movement. Bloody show can be a sign because that she could lose her mucus plug, which is mucousy and has blood in it. We also can see bloody show as the capillaries are breaking, as the cervix is softening and effacing or thinning, even if it doesn't mean she's in labor, but if she's starting to have some blood on her tissue, that can definitely be a sign that labor will be starting soon.
So
Sometimes
bloody
we don't
show
see
is like
bloody show.
spotting?
Mm-hmm.
Oh, okay.
And so if we see it and she's term, we're thinking she might be going to labor. If we see it earlier, then that's a warning sign, right? We shouldn't be seeing blood early on. But when we're close to time for labor, a little bit of blood on her tissue, like spotting, can be a sign that labor might be starting soon.
And what exactly is a mucus plug?
The mucus plug is this, it's a plug
A plug
of
of
mucus.
mucus.
It lives, I mean, I'm like, how could I say it any other way? It is that. So it lives in the cervix. And when we're getting close to, it just kind of plugs things off to try to keep bacteria and things from going inside. Once we're getting close to labor, sometimes we never see it come out, but sometimes it comes out in little bits at a time over a period of time. But sometimes it's like a glob that just kind of comes out of her. So sometimes I'll see patients that come in the hospital and they're like, I have this, it came out of me, and she brings me her mucus plug. I really don't need to see it, but thanks for sharing. Um, but it can have blood in it. And so sometimes women see the mucus plug and they think, I'm having a baby today. And that doesn't mean anything. Okay, but it just lives in the cervix until we're getting close to labor.
And is that the same thing like the rupture of membranes, or is that like before that happens? She loses that?
So the rupture of membranes is a separate thing
Oh,
where
okay.
if the water breaks, the membranes are the two thin layers, the chorion and the amnion, that encircle everything, and it holds the baby and the placenta and the amniotic fluid all in one thing like a water balloon. So the membrane is actually attached to the placenta on the edges, and then the baby and the amniotic fluid are inside. When the water breaks, that membrane gets a leak in it. It tears. And so that is a separate thing from the mucus plug.
Okay.
And the mucus plug won't keep the fluid from leaking. It's not like that solid.
Okay.
So if the water broke, it would still leak past it.
Okay, that's what I was wondering, if one thing causes the other. Okay.
Yeah, they're two separate things. A genetic disorder in which both parents must be carriers of a gene in order for the baby to have a 25% chance of expressing the disorder. So this is like your dominant and your recessive genes. Good. Your recessive has to have both genes of the pair in order for it to present itself. So I use blue eyes as an example. I have blue eyes. My husband has brown eyes. Half of our kids have brown eyes. Some of them have blue eyes because he carries for blue. And I definitely have blue. If I had brown eyes and he had brown eyes, but we both carried for blue, that's where we would get the 25% chance of it expressing itself. So that's how recessives work. You have to have it on both sides in order for it to show itself. The nurse is caring for laboring client, which statement indicates that the client is entering stage 2. Okay, so what is happening in the second stage?
Fully dilated, ready to push.
Yep. And so that's why blue isn't the best choice, because if the baby's coming out now, we're kind of at the end of stage 2. For some women, stage 2 is very fast. We're completely dilated to having the baby pretty quickly. But the second stage is our pushing stage. And so when she starts feeling the urge to push, we're checking to see if she's fully dilated. And then the pushing part, stage 2 can take hours. All right. The water breaking, that has nothing actually to do with labor. The water can break and she's not in labor, or the water can break at any point during the labor. So green isn't the best choice. And then I feel my baby moving around a lot isn't related to labor either. Okay. So second stage, I feel like I have the urge to push. Let's see if that cervix is completely dilated. And that would be an indication that she's entering the second stage. A nurse is reviewing fetal circulation. The client understands the teaching when which statement is made. You guys did really well with that one. That one I think you have to use a little bit of your critical thinking for. All right, so fetal oxygenation occurs through the placenta. When we talked about how are we perfusing the placenta, is our baby becoming hypoxic, oxygenation, we're all of that has to do with the placenta. If the baby's not using their lungs for oxygenation, so really the placenta is the one functioning for fetal oxygenation. A client assumes she's in labor, which assessment finding would indicate that the client is in true labor?
Oh shoot, I picked the wrong one. God darn it.
Okay, so how will I actually know for sure she's in labor? For sure.
Walking your wait.
The assessment of the
Sir,
cervix.
sir.
The cervix. The cervix doesn't lie. Okay, the cervix is either changing or isn't. That's really how I know she's in labor, is if the cervix is changing. But which of these are indications that these are contractions that probably are true labor contractions? It's going to be the lower back that radiates to the abdomen. If she's feeling them up high in her belly, those are often Braxton Hicks. Cervix is 250 and -1. Fetal heart rate is reactive and reassuring. What nursing actions would be best for this stage and phase of labor? Okay, what stage and phase of labor is this patient in?
The first.
Is one
She's in the first stage, and what phase?
latent?
Latent phase. So during the latent phase, we are encouraging ambulation is a great idea, okay, to kind of help things keep moving. Because remember that if she is in labor, ambulation will help. The contractions should increase in frequency and intensity. It helps gravity, bring the baby down on the cervix. All of these things are good. Plus, her moving around is going to be better for her mentality too, instead of just staying in her room or laying in bed. We don't need to monitor the fetal heart tones every 15 minutes. We're not assessing her cervix every hour. And we don't need her to urinate every 1 to 2 hours. So usually she should empty her bladder about every 3 to 4 hours. And so ambulation was the best choice for this. A pregnant woman being admitted to the birthing unit is described as having contractions for several hours, which are now 5 minutes apart. Her cervix is 580 and -2, and her baby is right occiput anterior. Her water is intact. Based on this data, the most appropriate nursing intervention for her might be what? So let's talk about her. That was a lot of information. So she's pregnant. She was having contractions for several hours. Her contractions are now 5 minutes apart. Her cervix is 580 and -2. Her baby is right occiput anterior. Her water is intact. So what stage and phase of labor is she?
One.
Stage 2.
I thought stage 2 was already 10 centimeters that I was in.
Yeah, second stage will be if she's fully dilated. How many centimeters is considered full dilation?
In stage 1 in active labor, active phase.
Yes, stage 1 active phase. And what centimeters is full dilation?
10.
10. So we're not to stage 2 yet, but she is in the active phase of the first stage because, well, technically now we're in a little bit of a gray area actually, because that we used to call active 4 centimeters. Now it's really more like 6. but she's either right at the end of latent or the beginning of active. We know that she's making cervical change. Her cervix is dilated enough that she's going to stay and have a baby. And so we're not at a point where we would not send her home. We're also not encouraging bed rest. This is another time that up and moving is good, and all of those non-pharmacologic pain management ideas are really great for her. So her controlled breathing, her using hydrotherapy, ambulation, also like gait control theory and massage, and all of those things would be great options for her until she either progresses to the point that she needs a push or she wants to do something different. Okay,
I have a
this
quick question.
patient is yeah.
I'm sorry.
I was just going to say this patient is the one that we would be thinking about. How is she coping and how can we support her and stuff like that. What's your question though?
Because it kind of like messed me up when it said take jacuzzi. Because I remember even it was 18 years ago when I was pregnant. The doctor said like no jacuzzi for pregnant women. Did it
Oh, we
mean?
put them all in the water.
Yeah, did it meant to say this just a tub?
No, a lot of the labor units have jacuzzis.
Oh, okay.
Yeah. A lot of the labor units have jacuzzis. And actually, though, it depends a little bit on how they clean them, and if they can keep their jets clean. But definitely, you can, like, it's safe for you to do it. It's now not in a hot tub, okay? Do you know what I mean? Like, don't go get in a hot tub at the local pool and the temperature is 120 degrees or something. But you can do the jacuzzi jets in the tub. So
But
that's okay.
they have birthing centers. They don't really have jacuzzis in hospitals like they used to. They have birthing centers that you.
They do in New Hampshire.
Oh, not in Ohio.
Okay. Well, she can have a jacuzzi if it's available to her.
Okay.
She's at this point in her labor that hydrotherapy, whatever that looks like where she's at, is okay. Ambulation is okay. Non-pharmacologic pain management options for her are great ideas. A woman in labor is 5 centimeters, 80 and -1. The fetus is left occiput posterior. The most appropriate nursing intervention to promote comfort and facilitate labor progress might be what? So this one is similar to our last one, right? She's also 5. But her baby is occiput posterior instead of occiput anterior, and so that causes a lot more pressure on her back. And so getting her in her hands and knees is going to help create space for that baby to rotate. And so internal rotation as the head is coming through the pelvis is going to help labor progress. So hands and knees is a good choice for her. And then this one is 6 centimeters, 0 station, contracting every 4 minutes and wants an epidural. In order to limit the risk of this procedure, the priority intervention is to do what? Okay. So do you guys remember what we talked about with what can happen with an epidural with the mom's blood pressure?
Hypotension.
So we preload with the IV fluid bolus to help support her blood pressure. Okay. What stage and phase of labor is she?
First, Latin is it Latin stage?
So she's 6 centimeters. She's active. She's first stage active phase. She wants an epidural. We're going to give her a fluid bolus to help support that blood pressure. Okay. And so that's going to be the most important thing. Monitoring the fetal heart rate is something that we will do, but it's not going to be, the question asks to limit the risk of this procedure to mom and fetus. So monitoring the fetal heart rate isn't limiting risk. So this is a good question where you can really look at what the question's asking.
Oh, the epidural interventions before the epidural. Okay.
Yep. One more question, guys. I can't believe we're still playing this game. When the cervix of a woman is in labor is dilated 9 centimeters, she states she has the urge to push. What action should the nurse implement at this time? Can she push?
No.
She shouldn't push, right? So why should she not push?
Because she's not dilated.
She's not 10. Okay, if she pushes before the cervix is fully dilated, then we're going to risk tearing the cervix or causing swelling. And if it tears, it bleeds like crazy. We don't want her to push yet. So this comes back to those breathing techniques to try to let her body finish dilating. Okay, so pant and blow during contractions, helping her with her focus, controlling her breathing is going to matter for this last centimeter dilation. She's not in second stage. She's not ready. Okay. All right, here we go, big winners. Yay.
Rika and Sade been on my tail this whole game.
Uh-huh. So as far as the game itself, I will try to do the setting that will let you guys download it and play it. It's only going to be good, I think, for like 7 or 10 days, but I'll send it out with the recording when I send it out to all the instructors to post, okay? Does anybody have any other questions?
Oh, thank you.
Me, I have my question.
Okay, yeah.
How many
So
questions are
let
on
me
the
stop our
exam?
recording real quick. I'm going to
Okay.
stop the recording if we're not, if we don't have any other questions related to this, but then we can definitely talk about your thing. Hold on.